around 55 million Indians are pushed to poverty in a single year due to healthcare costs.
Healthcare spend is the second leading cause of rural death. There are close to 30% of patients in this country who stopped cancer treatment because it is not affordable. Can you believe it? They just stopped because the families simply cannot afford beyond a point. You can imagine how difficult a decision it is to let a family member die simply because you can't afford further care. In India, the problem is the spend as a percentage of GDP on healthcare is honestly ridiculously low. So just to put it in perspective, it is estimated around 2.5%, 3% of GDP is spent on healthcare. Even, our neighbors spend a higher proportion of a smaller GDP on healthcare. The government is simply not spending enough money on healthcare because healthcare does not get votes. You created a system where the decision of whether somebody lives or dies depends on how much money they have.
And that's why you call it the sick business.
The episode that you're going to watch will truly shock you to its core. It will give you some deep and unsettling information regarding the Indian healthcare system that you wouldn't have known otherwise. And I think it's a big nexus that is happening. In this episode of Discovery of an Author, I sit down with Dr. Sumanth Raman to discuss his very powerful book, Sick Business. Now, Dr. Sumanth is a healthcare IT professional with over 22 years of experience in this domain. He has managed some of the largest healthcare implementations in hospital information systems and medical records space. He has been involved in design and development of cutting-edge healthcare solutions, including clinical decision support system, medical device integration, EMRs, and whatnot. He's a pioneer in this domain. And the information that he has shared in this podcast about doctors, about hospitals, about pharmaceutical industries, and how, what he calls it, a horror story, a sick business. If you do decide to listen to this podcast in its entirety, that these are the things that you'll get to know. You'll get to know the true state of India's healthcare system and why Dr. Sumanth calls it a horror. How over-testing and over-treatment exploits patients. The deep nexus between hospitals and Big Pharma. Why millions fall into poverty due to medical bills. And lastly, Dr. Sumanth's 5 strategies that every Indian should do to protect herself or himself from this ecosystem. I humbly request you to please share this episode with as many as people as possible, because we have all had people in our lives, in our families, who have suffered, who have been to hospitals, and who have also been cured. But it's very, very, very important. If you know Dr. Sumanth, if you want to support him, then please subscribe to this episode, like this podcast, comment and share. This is the only way in which we can grow. It's podcasts and episodes like these which actually, make me realize why I started podcasting in the first place. It is so that the information could help you and then you can take the right actions. I really hope that you enjoy this episode. I really hope that this episode enriches you, alarms you, alerts you regarding this ecosystem. And again, please subscribe to our channel. This is the only way in which we can grow and the only way in which you can show us love and support. Thank you.
Dr. Sumanth, welcome to Discovery of an Author podcast. It is truly our honor to have someone like you with us.
Thank you, Raghav. Thank you for having me. My pleasure.
Dr. Sumanth, I have to be very honest with you. I have done a lot of recordings. I have read, and we read each and every book before we can speak with the person. Yeah. Your book, Sick Business. I have never in my life taken so many notes and highlights in a book. It was mind-boggling. I mean, there were certain instances in the book wherein I did feel happy about the Indian healthcare system because there are positives as well.
Absolutely.
But I felt so scared. I felt
exploited also. I felt abused also. I also did feel that yes, we are living in a third world country. Because systems like these, they do show out, they put forth an image of a nation, right? It's very important from that perspective to measure where we are. So, Dr. Sumant, before we start, want to say something. So, I think this subject, I would like people to be very honest, like the way you have been in your book, which was brilliant. And yet also to be very sensitive to this industry, because I'm always somebody, though I have no connections in this medical field. My parents are not doctors, nothing. But I still have a deep reverence. Because in the end, this is what has been curing people,
Yeah.
right? You do go to medical doctors. Whenever, very simple example. So let's say when I or anyone in the family falls sick, the moment we enters a doctor's cabin, we automatically start feeling better
Absolutely.
because we know that we are now in the right hands. That is the power of this vertical in India, right? And the strenuous, education systems that these doctors go through.
Yeah.
But on the other hand, what I got to know after reading a book, that this is kind of like a nexus, a business, wherein not just one person is involved, there are multiple stakeholders. It's an industry that we cannot see as layman. You have to be a part of it to understand what is happening, which is scary. So, Dr. Suman, with this, my first question is, before we go into the business of this thing, before we understand why this is a sick business, I want you to explain to people the definition of healthcare. Let's first start with the foundation. What is a healthcare, and what are the entities or institutions or stakeholders that constitute this world of healthcare?
Yeah. So healthcare has a conventional definition, Raghav, and that is healthcare is a state of physical, mental, emotional, and social well-being, and not merely the absence of disease. So I think that this is something that all of us need to sort of understand. Just because somebody does not have a definite documented disease does not necessarily make him or her a healthy person. So healthcare definitions have been debated for decades, but generally the accepted one is, to put it in simple terms, you need to be physically healthy, you need to be mentally healthy, you need to be emotionally healthy, and you need to be socially, in your interactions with society, you need to be healthy. So all of that together is what constitutes healthcare. Just because somebody doesn't have diabetes, doesn't have hypertension, doesn't have ischemic heart disease, that alone is not a definition of being healthy. So that's what it is. And at the start, I just want to make one point. The purpose of the book is not to, to sort of, sensationalize anything. There are lakhs and lakhs of amazing doctors, great medical institutions in this country doing fantastic work. I mean, it's like you won't see institutions like these in most countries of the world, or doctors like these who work so selflessly. The problem is we've now created a system that is having an entirely different objective from just the well-being of the patient alone. And that is what the book seeks to highlight. It's not that the aim is to say that doctors in this country are bad. No, that's not the objective at all. But many of them, and let's face it, many of them are well-meaning doctors who are trapped in a difficult system. I mean, they need to keep the home fires burning. They need to. So it's not, the idea of the book is to create awareness among the public and make them understand. Look, this is a system that we all should be working to try and improve and change.
Absolutely agree. It's like there are so many great teachers who really want to impart good knowledge, but sometimes they get trapped in the system. And then they're like, we are too small to fight.
Exactly. Exactly. That is something which I see all the time, even among my own classmates and colleagues, who are, many of them are well-meaning people. It's not that they are, commercially exploitative people or out to make a quick buck. No, but the system that they are in the corporate healthcare sector does not give them the leeway to, I mean, they have the option of stepping out and, exiting altogether, but that's not a choice which, many of us would have the guts to take.
So, Dr. Suman, so now that we have understood healthcare, I just wanted to ask one thing. It is very interesting when you defined health, you also mentioned the emotional aspect of it. So, I want to know that why. You know, we have been going to doctors since ages, since we were children, right? Our parents have been going to the doctors. Very recently, there are two verticals which I feel were never there, at least I never encountered. One was the emotional wellness, as in none of the doctors never did. The discussions were not even initiated by the patients themselves. It's
Yeah.
not as if the doctors did not want to talk about it. This was a non existing entity.
Yeah.
It's only recently that people have started talking about the mental health crisis and therapies and everything, right? But before that, there was no talk of mental wellness. And B, which surprises me till date, is nutrition. So let's say you go to a doctor, you say, my stomach's not well, I've been having acidity and burps and farts and whatnot. Obviously, they'll prescribe you some syrups and everything, but rarely would I see a doctor or any ecosystem giving me guidelines about what I should consume. And I have grown up to realize, Dr. Sumant, that nutrition is very powerful, if not more powerful than medicine. So my question is, why do you think in this healthcare system there is the emotional wellness and the nutritional wellness part was not something that was?
Part of it is also because our understanding of how these impacted on physical health was not there maybe 70, 80, 90 years ago, the way it is today. So today we know much more how the mind influences physical health. Today we know much more how nutrition, impacts physical health. Today we know much more the role of gut microbiomes in physical health and their connections with the diseases which we would never have thought of were related to the gut in any way. So I think that part of the problem or part of the change is because we have now understood what contributes to physical health. So it's not just tweaking your organ systems physically. There is also a mind component to virtually almost all healthcare conditions, and we see that as medical professionals all the time. We see, the classic example which you would be given is pain. Pain tolerance is something which differs widely from person to person, and a lot of people who, I mean, we see example would be people who got joints which are completely destroyed, will complain sometimes of minimal pain and they'll still get by, and there'll be people with fairly intact joints who will complain of severe pain and say that I can't move, I can't do this, I can't do that. So the connection between the mind and the body has been much better studied in the last particularly in the last 2 to 3 decades, and that has meant that our approach to this whole, treating a patient for a physical ailment is no longer what it used to be maybe 50 years ago.
So the therapist of today and the nutritionists and the dietitians of today, are they also part of the healthcare ecosystem now, or are they also called doctors, is what I wanted to understand.
Technically, they are not. The obviously the mental health professionals, the psychiatrists are very much part of the medical ecosystem. They are doctors professionally. They do their MDs just like any other doctor. So they are doctors, absolutely. The clinical psychologists today aren't really called doctors as such, or they're not considered as medical doctors, but they have a very, very important role to play. Nutritionists are not called doctors, unless, of course, if they've done a PhD in nutrition, they would be a doctorate, and therefore they would be entitled to call themselves doctors, so and so. But other than that, they're not actually called as doctors. But let's face it, today, their role is no less important than that of the doctor who's giving you an antibiotic or who's putting you on any other medication.
So now that we have understood the definition of healthcare, now we have also understood why emotion and nutrition was not part. Dr. Sumant, who all stakeholders are there in the healthcare? What are the institutions that are involved in this ecosystem
of healthcare, like pharma and XYZ?
Yeah. So, in India, we have two broad streams. One, uh, the government is a huge stakeholder, right? Of course, we've got the patient at the end of the spectrum, but the patient should actually be in the center, because everything is basically supposed to revolve around what the patient needs and what the patient's requirements are. But you have the government. In India, the problem is the spend as a percentage of GDP on healthcare is is honestly ridiculously low. So, just to put it in perspective, it is estimated around 2.5%, 3% of GDP is spent on healthcare. And a country like the US, okay, the US, there is a lot of waste and there is a lot of money being made, which really shouldn't be. But the US spends something like 15% to 17% of its much larger GDP, a GDP 5 times bigger, 6 times bigger, on healthcare. So even our neighbors spend a higher proportion of a smaller GDP on healthcare in South Asia, right? So one, we have to understand that our spending on healthcare is extremely low. It needs to go up. The government is simply not spending enough money on healthcare because healthcare does not get votes. It is believed conventionally in India that if you spend on healthcare, it's not as big a vote gathering issue as, say, giving away a few freebies. So between establishing a public healthcare system that works great and giving 1,000 rupees a month to everyone, most politicians or governments would prefer to give 1,000 rupees every month, right? So that's a problem. Then you have the private sector. The private sector has two broad components. You have the corporate sector, which caters to a very small portion of our population, which I would say 90% of India simply cannot afford corporate healthcare, where one major illness will bankrupt the family, right? So these are, today, if you take a metro city in India, ICU care will cost around 1 lakh rupees a day. And I'm not even talking of Mumbai and Delhi. I'm talking probably of southern metros and a few other, maybe even tier 2 cities will cost 50, 60, 70K a day. Now, that's not affordable on a sustainable basis for people. So, 90% of India can't afford this corporate healthcare. Then you have a small number of trust hospitals, charitable hospitals, those that, subsidize poor patients, charge the rich patients. Various models are there. So you have Indian healthcare in three large buckets. One is the government, which by and large, the general assumption is if you can afford treatment, you wouldn't want to go to a government hospital. That is the tragedy, because there is no substitute for quality healthcare except than a public funded healthcare system. You can have you can have private hospitals, you can have corporate hospitals, all of that, but you still need a well funded, well run public healthcare system. So India stakeholders, of course, are hospitals, doctors, laboratory diagnostic centers. You've got the health insurance, which constitutes an increasingly important part of the ecosystem, the governments, the pharma. So, and of course, in the middle of all this is squeezed the poor patient.
Because India does not spend a lot of money in public healthcare, is that the reason, Dr. Suman, that the government hospitals are in deplorable states? The care is not there, the facilities are not there, or is it just because of the overpopulation of this country? Because when we do speak on this topic, even when I'm having a conversation with my friends over a coffee or whatever, they're like, "Ki Raghav," I'm going to say something in Hindi. They're like, "Arey Raghav, is desh ki janta dekh yaar. Look at the population of this country." It seems that this has become the answer to everything in this nation. And sometimes I also ponder, and then I'm like, no, dude, look at China. And they're like, hey, don't talk about China. They are, military, they're autocratic, they're not democratic, and this and that. So I want to understand, is it just because of the population, or is it because of the very small amount of investment that goes into the public healthcare? That is why the state of public or government hospitals is so bad. आई एम सो सॉरी फॉर द सडन इंटरप्शन. ये हमें करना पड़ता है और हमको इसी प्रकार से इंटरप्ट करना पड़ता है. बट आई हैव अ रिक्वेस्ट कि गाइज, अगर आपको थोड़ी भी वैल्यू लग रही है
in what we are providing with our podcast, in the kind of content that we are creating, and in the kind of people that we're bringing on our show, please subscribe to our channel. This is the only way in which any podcast on YouTube can grow. It will cost you nothing. आपने सिर्फ सब्सक्राइब करना है, and trust me guys, if you subscribe to this podcast, we'll make sure that we continue delivering you such amazing कंटेंट, इंटेलिजेंट कंटेंट. हम एक इंटेलिजेंट पॉडकास्ट क्रिएट करने की कोशिश कर रहे हैं. दैट इज वाई हमारे जितने भी गेस्ट होते हैं वो सारे पब्लिश ऑथर्स होते हैं जिनका वर्क के देयर इज अ बैकिंग टू देयर वर्क. कोई भी कुछ ऐसे नहीं बोल रहा. सो गाइस, प्लीज सब्सक्राइब टू आवर चैनल and continue enjoying and listening to this episode.
There are a multitude of reasons. Obviously, there's not one single reason alone. But one of the first, you need to at least double your spend. And I'm saying that in a sort of that's the minimum that you need to do. If you're spending 2.5-3% of GDP, it needs to become 6 to 7% right away. Otherwise, making a big impact is going to be a challenge. The second part is the lack of accountability. I mean, this is not just a healthcare problem. It's across any government department is badly run. By default, it is badly run. There is corruption, there is nepotism, there is political interference, there is every kind of issue that you associate with governance in India, which also plagues the healthcare system. So why should healthcare alone have greater? So the doctors who should come at 8 o'clock and be there till 4 o'clock, they will probably saunter in at 9:15. They'll push off at 12:31 in the afternoon. They'll take turns coming. Two doctors will be posted. One doctor will come Monday, Wednesday, Friday. The other doctor will come on Tuesday, Thursday, Saturday. No accountability. Nothing happens. People at the higher level get paid off. These are not unique to healthcare. They are unique to government. Across the government, you have the same problem. The third is the government's the third is the population issue. But that's more a distribution-related issue. So you have All India Institute of Medical Sciences in Delhi, which draws thousands and thousands of people queuing up in the OPD every single day, and they're struggling with the load. And then you have all these AIMS centers in different cities, which are pretty shambolic. In the hope that they will distribute the load which comes to AIMS in Delhi. They decided to have AIMS in other places, but the AIMS in other places are poorly staffed. Many of the specialty departments don't have doctors. They don't have the adequate infrastructure to meet. And gradually what happens is the public realizes, oh, the care is not very good here. I might as well go to Delhi. So again, there is overcrowding in the central hospital. So I would not say today population is not, I would not say population, blame population for the issue. Today we have a fair number of medical centers in tier 2, tier 3, and in primary care. Primary health centers, for instance, the state I come from, Tamil Nadu, primary care, I would say, is on par with anywhere in India. And we have a system where, in some cases, primary care is even better than secondary care, even in our own state. So there is funding for whatever is there, but to run them well, to keep the hospitals clean, to prevent visitors from coming in, to prevent infection, which kills large numbers of people, to know how you are doing as a hospital is the biggest challenge. We do not track outcomes. So if you go to a government hospital and say, how many bypass surgeries did you do in the last 1 year? They will give you the numbers. They will say, we did 84 bypass surgeries. Then you say, how many of these patients are alive today? They have no clue. How many of them developed complications? How many of them, went into, had an unforeseen event? What is your success rate? Nobody knows. So this is the problem with government. It's not just a question of money alone or population. It's also the governance structure of public health, which is the same across, whether it's in government education. Why are government schools so bad compared to private schools in most of the country? The same thing.
Very interestingly, you said that, Dr. Sumanth. I was in one of the podcasts, I was having this discussion with a very famous journalist, Ashutosh. And I asked Ashutosh, Ashutosh, it's not as if, so let's say the ruling party
Yeah.
I'm sure the ruling party wants good things to happen, right? Let's say Narendra Modi led BJP, they want India to become,
Yeah.
a very developed nation. But I'm like, I cannot see that in their systems. I cannot see it trickle down. I cannot see in the way they are organizing. So I asked him, is it because of lack of intent, or is it because lack of skill? He said, yes, it is because of lack of skill. It's not about, of course, any ruling party would want good things to happen
Yeah.
to the nation. So does the same logic also apply? So it's not just that, yes, there is corruption. I also want to know the people, the government bodies who are in charge of running the healthcares, do they even have the skill to systemize things, to organize things, to manage things? Because that also is a big loophole if that's missing.
To some extent, they do, but to a large extent, yes, this is also a problem. Look, for a doctor, I'll give you an example. In developed countries like the US, for instance, every 5 to 10 years, the doctors need to get recertified. They need to have their periodic, evaluation done. They need to attend a. Oh, it's only in the last 10 years that we've even woken up to the fact that doctors need to get their CME credits and so on, which their continuing medical education programs and so on. So now there is a challenge in the sense that what our entire philosophy of healthcare in government sector is driven by what is called quantitative healthcare, not qualitative. Quantitative healthcare means if there is a hospital, if there is some medical equipment, and if there is a doctor, healthcare is being delivered. That's the assumption. It whether that doctor is qualified, how well equipped is he, how is he performing, what are his outcomes, what are the what is the feedback from the patients in the community, we don't know. As far as I am concerned, I have built a hospital, I have given it the equipment, and I've given it the doctor. Thereafter, healthcare has been deemed to be delivered. So all our statistical reports that we get are largely we have created a primary health center for every X of this population. We have done we have provided ultrasound machines to 8,000 hospitals. So all of our I'm not saying quantitative healthcare is not necessary. Obviously, it's needed. I mean, a doctor can't do anything if he doesn't have the equipment there. But the bottom line is that alone is not enough. How are the outcomes? So I think I'll give you a classic example. The government pats itself on the back, saying that our infant mortality rate has been reduced, our maternal mortality rate has been reduced, and so on. But that has been a global trend following the introduction of antibiotics and the better management of infectious disease world over. So the point I'm trying to make is, just as we have an focus on quantity delivery in healthcare, we need to focus on the quality. And in government, very, very few things are being measured. All that is being measured: number of patients who came, number of antenatal mothers and mortality, in terms of how many deaths were there, especially in the antenatal system. So I think there needs to be a change of approach too.
It's the equivalent of saying that in a school, in a government school, just because the teachers are attending and the students are marking their attendance, they should come out with a good grade and good.
Exactly.
It doesn't make sense.
It's exactly that's exactly the analogy. And the assumption in government is, therefore, healthcare is deemed to be delivered.
Accountability is not there. They're not. So again, they lack systems to check what is happening. Just establishing, it's like you have WhatsApp. You can see the front end, but there is no back end.
Yeah.
If there is no back end, no message is going to work, right? Because your
Yeah.
architecture is not there. Just
Exactly.
because you can see the interface, that does not mean that something is working. And I think it's all boils down to the vote bank. Look at how many hospitals has been created. Look at this. Look at that.
No, that's what I use the term, the curse of visible spending in healthcare. It's called in fact, I mentioned it in the book
Yep.
also. It's called the curse of visible spending.
Yes.
Every politician, between two things, between running, let us say, a training program which will equip your doctors with the latest trends in a particular field and empower them to treat their patients better, and maybe putting up a new building. 99% of governments will prefer putting up a new building. The building can be inaugurated, There can be photographs taken, and this will be there for the life of the politician to say that, look, I brought this to this village. I have brought healthcare to this village. Now, how do you measure the fact that the doctors whom you trained actually treated patients better, and because of that, the patients in the village got benefited? Who can see that? They can't see that. Whereas they can see the shiny building or the fancy equipment that has come there, and whether it is used properly, not used, is sort of breaks down after 2 years. All of that is not something that gets written about. Whereas new clinic opened by so and so, and Mantri ji has come and inaugurated it. That's where the focus is. The focus is on visible. I'm not saying that's not needed. You need that too, but that alone will not get you quality healthcare.
Yeah, it's a finger, not the hand. It's one finger.
Exactly.
It's one part.
Yeah.
That does not mean
Yeah.
that's the entire hand, right?
Absolutely, that's the problem with government, in healthcare in India.
Yeah, beautifully said. So I am just going to say the highlights that I have taken from the book, and then you explain, where that is coming from, because I just want this to be a masterclass on what is happening for people to know.
Yes.
Right. So the first highlight which I want you to explain is around 55 million Indians are pushed to poverty in a single year due to healthcare cost. Now, Dr. Suman, there are two words which are very scary. Poverty. Like, poverty is a big word, right?
Yeah.
It's like saying bankruptcy in a single year, and that also due to healthcare cost. So
Yeah.
please dissect this.
Yeah. So this statistic is actually a well-documented statistic. I think the number is around 18 million families. So 55
हाँ,
million
ठीक है.
is an extrapolation of
Yeah.
that, who get pushed into poverty. Now, there are two major reasons for that. Now, all of us know that healthcare spend is the second leading cause of rural debt. So, rural indebtedness happens largely to a significant extent because of healthcare spending. So, a classic example: somebody in the family develops cancer, and the family has to go for treatment. So they start off, chemotherapy costs so much. If they go to a non-governmental center, and very often that is again a problem because they don't have faith in the government system. So they will go to a private center, money gets exhausted, they sell the land, again money gets exhausted because cancer treatment can go on for years. It's not a question of 2 visits or 3 visits, and it goes on for years. The family property gets depleted, and at some point there was one other statistic, I think, that there are close to 30% of patients in this country who stopped cancer treatment because it is not affordable. Can you believe it? They just stop because the family simply cannot afford beyond a point. And I've highlighted some cases in the book as well. So you can imagine how difficult a decision it is to let a family member die simply because you can't afford further care. And that happens every single day in this country. Nobody seems to care about it. That families are giving up on treatment, giving up on a mother, giving up on a father, simply because they cannot afford. They have sold everything they've had. They've spent all the resources. They've borrowed heavily. It will probably take them another 5 years to 10 years to repay the debt. And then at the end of it, the person may still not survive. So they take a very painful decision saying, let's stop treatment. This happens every day in India, and it doesn't seem to bother any of us at all. So that is a massive concern. And if you talk to families who've been affected, as we doctors tend to do on a regular basis, it's an extremely difficult task, because I mean, you've created a system where the decision of whether somebody lives or dies depends on how much money they have, and we are okay with it. I mean, the country as a whole seems to feel it's okay. That is what really, in fact, that was one of the things which prompted me to even raise these issues or write the book.
And that's why you call it the sick business.
Yeah. See, the reason is, today, what is a hospital? A hospital is not a healthcare center. It is a disease treatment center. You don't go to a hospital when you're healthy, right? Or you don't go, you go to a hospital when you have, or when you believe you have a disease or you have an illness, right? So the aim of the hospital is to cure you of an illness. Now, of course, you can say that there are wellness centers coming up and all that. But in our country, unfortunately, wellness has become a concept that can be used by hospitals to sort of pull patients into the healthcare system. So that's a long topic. I'll talk about it a little later.
No, I mean, you're absolutely right, because even when I go to these private hospitals, it's one thing for people living in the rural areas to take up loans to get treated. But what really breaks my heart, Dr. Sumanth, whenever I have seen it, is the way still they are treated in the private
Yeah.
hospitals. And I'm like, they are humans. They're not here for free. They are paying it. Why is there no humanity? Why the sudden rush? Why the sudden anger? There have been cases wherein I took somebody who was going through a stage 3 or stage 4 cancer to a very famous doctor in Jaipur, because that is where I'm from. And that was a very revered doctor, in a sense that he has been practicing since many years. And the only thing that I took away after his appointment, Dr. Sumanth, was that his rudeness, his dismissive behavior. So I don't understand where this is coming from. If it can happen to people like us who are living in urban cities, who are highly educated, who can afford, and yet you have this rudeness, which is, we've all been through that. So
But
imagine what is happening
Raghav,
to the rural people.
1 minute, 1 minute. In your MBBS, you are never taught empathy. You are never taught ethics. You are never taught all this. I mean, you learn anatomy, physiology, biochemistry, pathology, microbiology, pharmacology, medicine, surgery, OG, blah, 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 blah. But you are never taught what should be your bedside manner. You're never taught this. And it's strange. Ethics, of course, now they're trying to introduce some courses and papers and so on. But it's still, it to me, that those subjects are possibly as important as anatomy or physiology or biochemistry, but they are not taught. There is no medical college which actually spends half a semester training patients, that training doctors, that this is the way you should speak to patients. This is the way that you should convey news which may not be palatable. That doesn't happen. And we've been through this for how many years now. We've the medical treatment, the medical education system was not started by us. It was started during British times. My college was the college I studied from, Madras Medical College, in 1835. What are we talking about? So my point is, if I'm not taught something, then how do I even know how I should behave? It is not part of my curriculum. So there is a problem. There is a problem. And I think that the NMC, MCI, whatever, they've started realizing it's an issue. But I think right now also it's too little.
Yeah, no, that you're absolutely right. I mean, I couldn't, I was just listening and I don't know what to say. You're so right. And as patients, as people who are on the receiving end of the treatment, we know what a world of a difference it makes.
Exactly.
I mean,
even one sentence, Raghav,
yeah,
the way a sentence is communicated, patients hang on to every word. They are searching for hope in every little word, every little inflection in the tone of your voice. They're looking for something that they can hold on to for hope. So, and we're not taught that. I mean, what can be more important for a doctor than teaching him or her empathy? And empathy is not taught in MBBS, it's not taught in MD, it's not taught in DM, it's not taught in MCH, it's not taught anywhere.
Because, Dr. Suman, another thing which I wanted to just say let's say from a patient's perspective, when we are in a clinic or a hospital and when we are, seeing a doctor,
I don't know if they know that, but at that moment for us, that person is not a mortal man.
Absolutely.
For us, he's a god.
Absolutely.
It doesn't matter who you are. It doesn't matter if you're a military guy, if you're in Indian army, if you're brigadier, if you're colonel. At that point, you're a patient who's suffering and who
Yes.
just wants to get rid of that goddamn thing. For him, I'm not looking at a mortal man. I'm looking at a revered figure, somebody like an avatar. And then if that kindness is not reciprocated, right, it shatters your faith in the entire institution.
Yes, it does. It does. And unfortunately, I think that, rather than blame all doctors, I think we also need here to blame the system that does not equip them, does not teach them that, look, this is not acceptable. You cannot shout at a patient. You cannot be rude to a patient simply because, he's poor. That is never taught. I mean, some of the people whom I revere and I look up to as my teachers were those who had this empathy. They were very good, great doctors also. But the point is, they would, they would sit by the patient's bedside, they would hold the patient's hand and communicate. And we could see the remarkable, change that they could bring in the lives of those people. Unfortunately, today doctors, combination of things, the busy ones don't have time. So, you can't spend 20, 25 minutes allaying every fear or every question that the patient may ask because there are 30 patients waiting in the queue. So there are a combination of reasons, but I think that this is something which needs to go into the curriculum.
Yeah, kindness is a medicine which needs no prescription. This is
Absolutely.
something
Yeah.
that should be given.
Yeah.
No,
Very true.
agreed. No, but strangely, if you go to their private practice clinics, no complaints. I mean, they will give you 40 minutes, 45 minutes, 50 minutes if required. Why is that? Why is that? There are people who are waiting. Even in the private clinic, if it's a famous doctor, there are people who are waiting. But more or less, they are more patient and kinder when they are in their private practice that happens after 6 p.m. or 5 p.m.
Yeah, I think one is obviously the fact that you're paying them for their services, whereas when they're seeing you in government, you're not actually. I mean, they're getting a salary, but I mean that's in general applies to all government servants. So I think that that is an approach which may not, we can't blame doctors too much for, because again, there is an overwhelming crowd in the government OPDs where, for instance, an average in a government in a large government hospital, the doctor may spend not more than 5 minutes with the patient because you don't have time. There are 40 people waiting for the and you've got maybe 3 hours OPD or 4 hours OPD in which you need to see 50, 60 patients. So you just simply cannot spend more than 5 minutes with every patient. So you're pretty much, and that is another problem I have, because in 5 minutes you could miss a lot of things.
Yeah. You have mentioned that
And
in the book as well, very elaborately.
absolutely, absolutely. So you can miss a lot of things. So, classic example is, uh, if you go to see a doctor first thing in the morning when they are fresh, when they are energetic, you probably have a better chance of getting the appropriate care than if you see them at 7:30 in the evening when they are ready to drop. Maybe the wife is calling and saying, "Why are you so late?" And we are waiting. The kids are waiting for something to go out somewhere, and he's harassed, hassled, tired, mentally fatigued. Who knows what else can be missed?
No, absolutely agree. Dr. Suman, the next thing which I want you to explain and just to expand on is another highlight. What initially started as a patient centric approach has been transformed into a bottom line focused approach. So because this was a very technical line, so I want you to explain what do you mean by initially started as a patient centric? Are we talking about initially in India or globally? Because this is a global system that we have
Yeah.
adopted allopathy. And then what do you mean by transformed into a bottom line focused approach, and who transformed it? Who are the players and what are the repercussions?
Okay. In India, at one point of time, healthcare was largely government and charitable and trust hospitals. There were no corporate hospitals. Until the early 80s, there were no corporate hospitals in India. From the early 80s onwards, corporate hospitals started to emerge. Now, corporate hospitals are not all bad. They have today, you get care comparable with the best in the world in many of these corporate hospitals for people who can afford such care, right? Now, the problem is that there is a mad craze to among the smaller hospitals to emulate the corporate hospitals. So what today we also see patients. Patients don't want to go to a nursing home. They don't want to go to a mom and pop clinic. Everyone wants to go to a branded corporate hospital. So in Tamil Nadu, for instance, the ultimate that a son can do for his father when his father is in bad shape, critical, is that he can take him to this particular branded hospital. So they will. The joke is, we did everything for him. We even took him there. I'm not naming the hospital. Everyone knows.
Yeah.
The point really is that corporatization of healthcare has meant, look, there are costs in healthcare. Let's be very clear. So you can't, corporate hospitals cannot be doing charity. They are not, that is not their business, right? The point is, can corporate hospitals run by only doing what is necessary for the patient? That is the part that we are looking at. Now, it seems that a large number of them may not be able to make ends meet just by doing what is in the best interest of the patient alone, because that may not be enough to financially fund the expansion or the continued operation of the hospital. Therefore, you need to generate. The second, very important, you need to generate revenue all the time, and significant revenue, which is more than your cost. Second, now in corporate healthcare, who is the primary responsibility to? Is it to the shareholder or is it to the patient? And if there is a conflict between the interests of the shareholder and the interests of the patient, whose interest should gain precedence? Which is the fundamental problem. Now, these patients, so I'll give you an example. Many corporate hospitals track the utilization of equipment. So I've invested 2 crores and I've got a CT scan machine, let us say, and I want to track which departments are referring patients to CTs. So periodically, the GM of the hospital or the operations head would have meetings, review meetings with the departments, and say, you know what, this department has not been utilizing CT scan, so maybe it would be good if this department could also start utilizing the CT scan. They may not have been utilizing it because their patients may not have required it. Now, what message does this send? So what happens is, when you have a conflict, and there's this conflict of interest comes every day. Who am I? Who is at the heart of my actions? Is it my shareholder or is it my patient? And this conflict is every day. Patients don't require a lot of tests in some cases, but you need to keep the shareholders happy as well. You need to generate year-on-year growth. You need to generate profits. So, I mean, obviously, you have a bottom line focused approach. So, the corporate sector having a bottom line focused approach is not something that the corporate sector can be blamed for. The point is, since you don't have regulation, Raghav, the healthcare industry is one of the least regulated industries in India, right? So virtually nothing except putting an MRP cap on essential drugs, and that also on a small number of drugs.
When you say regulated, that means in terms of their operations, in terms of the prices, in terms of their diagnosis. That's what you're saying.
Every single aspect. It is one of the most unregulated industries in India.
But
And
not the world. Not the world. You're specifically
no,
talking about India.
absolutely. If some of the things which happened in Indian hospitals happened in, say, the US, doctors and hospitals would lose their license. But in India, pretty much the corporate sector has an approach that, honestly, let's be very clear, anything goes. And the reason for that is very simple. Every big politician at some point will need the services of those corporate hospitals, right? For themselves, for their family members, for their, near and dear. So there is no way that they will, clamp down on them when they when they know that tomorrow they could be lying in the ICU of that same hospital. So it is a challenge globally, but in countries like the US, there are certain red lines which are drawn, saying that look, you can't do certain things, and overcharging, for instance. So I'll give you a simple example. There are corporate hospitals which charge 20,000, 15,000 for an MRI. An MRI typically on an average in a center would be around 4,000-5,000 bucks. In some centers even less, but let's take it around 4,000-5,000. So I can understand a corporate hospital charging 7,500 or 10, but 20 and 30 completely unregulated. Now the argument is, look, you want, and the argument which I don't really agree with is, you go to a Taj or you go to a five-star hotel and you have a coffee, it's for 500 rupees. You go to a roadside shop, you have coffee, it is 20 rupees, 10 rupees. I mean, it's the same thing. Why do you go there? But you have to understand that a lot of patients, nobody goes to a hospital because you enjoy going to a hospital. I've never come across anybody who says, oh, I love going to a hospital. No, you go because you have no choice, right? And to say, very often patients are admitted in an emergency, and their only thought in their mind at that point is trying to save a life of their near and dear. So to equate this example, saying that you have a coffee at a five-star hotel and this, I don't agree with that.
I mean, that is a lot to think about. I mean, what you're saying, Dr. Sumanth, is it sometimes can. That's what I was saying. When I read, I felt as if I belonged to a third world country. Because I know that we do have the potential of becoming a medical powerhouse. There is a word which is called medical tourism, right? So
Yes.
so on one hand, you have something called a medical tourism, which is there. I've seen that in a particular hospital in Delhi. I've seen people from other countries coming to that hospital. Now, I don't know if it is because of the affordability. Let's say people from African countries, Arabic countries, Afghanistan. A lot of these people come to this particular hospital in Delhi to get treated for chronic diseases and conditions.
Yes.
Now, I don't know whether their reason for coming to Delhi is just because of the affordability as against their own countries and systems, or is it the skill? And if it is a combination of both affordability and the skills of the doctor, that means India has the potential and some of the best pools of doctors in the world, and yet it is unregulated and exploitative.
The point is, if India had a better regulated system with the skills that our doctors have at many of the best centers in the country, they could attract patients from every single corner of the world. We could be a medical tourism capital. The problem is, people come to you from Africa, they come to you maybe from some Middle Eastern countries, but you don't get a huge number of, say, Americans coming in or Europeans who are coming in for medical tourism and treatment. This despite the fact that often you may have to wait for 1 year for a surgical procedure in the UK. If it's an
Is it?
elective procedure,
Is it?
yes, you have to wait 6 months, eight
My
months if it's an
God.
elective procedure. Sometimes it takes you, to see a specialist, it can take you 2 months or 3 months. So, despite that, they don't come here. That's because they don't know about the infection rates, they don't know about the outcomes, they don't know what is the success rate of a particular hospital in a particular procedure. Nothing is known. Government doesn't ask for it. The hospital doesn't, unless they use it in their ads to say that we've got 99% success in something which nobody is even able to cross check or verify. So the government simply does not regulate. The biggest challenge is nobody knows. Do you know how good your doctor is? The answer is no. You know, probably because your neighbor may have told you, yeah, he's a very nice
Or
doctor.
Google
Or
review.
your uncle,
Yeah.
Google reviews, yeah, which any review can be
Yeah.
manipulated. That's
Yeah.
Forget that. But the point is, there is no method. Supposing somebody in your family needed a knee replacement, and you're going to an orthopedic surgeon who does this. Do you know how many replacements he has done? What is his success rate? Nobody knows. I mean, he may put up to advertise himself saying, I've done 8,000 knee replacements and my success rate is 99%. But that's what he is claiming, or the hospital is claiming. You have no way of verifying it, or you knowing it. No outcome is being measured in this country. So you go to a doctor purely because your uncle told you he's good, your brother told you he's good, or you went there earlier and you had a positive experience, he spoke to you well, and you were happy with what happened. That's about it. You have no way of objectively knowing how good the doctor you went to is.
I mean,
And that is necessary.
if India has the potential of becoming the medical tourism capital of the world, okay, let's take it from the perspective of pure business. Okay, if India has that potential, that means if we tweak certain things, if we do proper regulation, we can unlock that and generate more revenues. So if this is a business, are they not hampering their own growth by not regulating it?
No, but I think you cannot selectively do that only for patients who come from abroad, right? You'll also
Acha,
have to
acha,
do it for patients who are in India, and then all the muck starts coming out. All the unnecessary
acha.
procedures, all the unnecessary surgeries, all of these things will start coming out. So I think we will get there when these hospitals themselves, when volumes start to drop for corporate hospitals, as at some point they will. It's not an endless gravy train. So at some point, at that stage, you'll find that corporate hospitals themselves welcome more regulation so that they can potentially increase their revenues. But until then that happens, I can't see this change. There is a huge opportunity, but the government will not regulate. Let me tell you something. The government of India until this date does not mandate a electronic medical record. There is no
EMR.
there is no mandatory need for a hospital or clinic in this country to maintain an electronic record. For an outpatient, I don't even need to legally maintain a physical record. I can write it to you in a piece of paper, give it to you. If you lose the slip, too bad. It's only in patients that there is a law which says that for 7 years or whatever period I need to maintain. If it's a medical legal case, it's longer and so on. But the point really is every country in the world, every developed country has moved towards mandating electronic medical records. Why has India not done that? You can't say we don't have computer skills, we don't have software skills, we are one of the capitals of the world. So, what is preventing you from saying, look, we'll give you 5 years' time and you need to move to an EMR? For the first 5 years, we'll incentivize you. That is how America did it. That is how the UK did it. That is how Australia did it. That is how every country in the world that has implemented electronic records do it. You will not be allowed to practice if you don't have an electronic record. And then you can start collecting that humongous quantity of data, and then you get the outcomes. Then you get every single thing flows from that. The government still. I was on the a part of the National EMR Standards Committee many years ago, and we tried our level best. But government said it is recommendatory. And when in India you recommend something or you say it's a good thing that you should do, nobody really cares. So I think that one of the first things that any government should do if they're serious about improving healthcare is to say, look, electronic medical records are mandatory. If you don't have them, you can't practice. Obviously, it can't be done in a day. Give the country 5 years, give the medical system 5 years, and say in 5 years you need to have systems in place.
And
That's not there. See, there are certain unique problems in India, and one of the problems is the doctors don't want a electronic trail of how many patients they are actually seeing. It could be for tax purposes, it could be for various reasons, but they don't really want this. So you go to a big hospital and try to sell them a hospital information system or EMR. One of the first 5 questions will be, how do I delete a record? Another question will be, can we maintain 2 sets of books in the system? So it's sad, Raghav, but I mean, I think people need to see that this is where we are. It's all very well. These are all not. I wouldn't say they're all bad people, or I can't sit
no,
and
I know
pass
that.
judgment
Yeah.
over them.
Yeah.
They're just people who are working in that particular sector for many years. That's how they've been working. That's how the system goes. So, and the most important, they are worried about having a trail. Right now, I write a piece of paper and give it to you. it's very likely that the piece of paper could be lost by you, which is great because then there's nothing to link me to what I did right or wrong. Now, if it's an inpatient record also, let's say that something wrong has happened, right? And you sue me. Now, all I need to do is to pull out one page from that and reinsert some other page saying I've done everything for you. Finished. End of story. Now, how do you do that in an electronic record? There is an audit trail. There are log files as to who accessed it, who made a change, what was changed. Everything is in the system. So there are many reasons why the medical community does not want an electronic record.
Yeah.
So
I could see that.
yeah. So that's the biggest challenge. So, and obviously they say, will it get me more revenue? So when you go and say, look, on its own, it'll help you treat your patient. One of the things that I've understood in 30 years is in corporate healthcare, patient care or patient, the patient care comes probably at number 5 or number 6 in their list of priorities. So so whatever you do, unless you show that it can enhance their revenues, they're not really keen on it. So you take an equipment, you say, already he's calculating, okay, how many cases of this would I get? So I can put 20 cases a month. So 20 cases a month into so much is this. And you go and try to sell them an EMR and say that, this will help avoid medical errors. It will pick up drug-drug interactions. It will make, care better because it gives you the summary of the earlier visits. Everything will be instant. And then he looks around and says, so how is it going to help me get more patients? So that's the problem.
So it's a transactional based approach first, not patient centric. It is transactional based.
Absolutely.
Dr. Sumanth, another thing I wanted to discuss and please expand on this thing, because your book has a lot of examples which really shocked me of how a patient was absolutely fine due to some reason, just because of regular checkups. They went to a particular doctor. He or she recommended that you perform certain tests. Certain markers came up in the text which were not detrimental to a person's health, and yet they were talked and they were shown as if something big has happened, and then a lot of medical things started happening. You have also mentioned about how there are certain scans when you particularly do on a girl or a woman, even if they do not have any cancerous indications, they end up having that just because of the scans or just because of the certain. So that really shocked me. So which brings me to another highlight. And please explain. So I want to understand. So there are two highlights. I'm just clubbing and you can give a common answer for that. One says, it is well established that if you do enough tests, you will find at least one abnormal result, even in a healthy patient. And a follow-up highlight is thousands of surgeries performed every year are medically unnecessary, including C-section, cardiac and knee replacements.
Yeah. So let me say that none of this data is from India. These are validated American data which have gone through a very rigorous peer review and have been published. So essentially, a lab test, when a normal range is given, that normal range is given for 95% of patients. So 95% of all individuals will fall in between the range which is given there. So by definition, 5% could be outside that range. That does not mean that they all have a disease. So if you do enough tests, you will come up with something which is fractionally, outside the range or below the range, whatever. So this is something which is well established, which is why the master health checkup industry is something that actually is used to get patients into the system. See, Raghav, there is a very, very important thing. Today, patients are not treated for a disease that they have. They are treated for a disease that they may or may not develop in 10 years or 15 years or 20 years. You're not actually being treated for something that you already have. That's, of course, if you have a condition, you go to a hospital, you get treated for that. But The vast majority of patients who are going into preventive checkups are then told that you may be pre-diabetic and therefore you may require this, or your lipids are high, so therefore you need to start on a statin, and so on. So you're actually being treated for something that you may or may not develop. So very often these, let's say that there is a 30% risk in 10 years that you may develop something if you don't take this tablet for the next 10 years. That means 70% you will not develop it. Correct? There's only a 30% risk. But nobody thinks like that. Even if I tell you there's a 10% chance in 10 years you're going to have a heart attack, I'm sure you'll start taking the tablet today. You won't say, "Arey, this man told me 10%. That means 90% I won't have it." Right? So that is the change. And the point is, evidence is constantly changing. Evidence is constantly changing. So I'll give you a simple example. When I was doing my MBBS, up to 140 fasting, and then it became 120 fasting. 120 fasting was considered absolutely fine. You weren't called a diabetic if your fasting blood glucose was 120, right? Up to 120 was fine. Then it became 110. Now it's come to 100. Now people are the same. Now you bring it down to 90, hypothetically, and say that 3% of people who had fasting sugars between 90 and 100 became diabetic after 25 years. Then the whole world can be called diabetic and put on medication. So one of the things that healthcare has missed is called acceptable risk. What is the risk that is acceptable? There is no definition for that. Right? In healthcare, it is zero. Even if there is 1% chance that something could happen to me after 10 years, I tend to start taking some medicine. So I'll give you a simple example. We go for a walk down the road. Now, there is a 1 in a million chance that you could be knocked down by a truck and killed. Now, you don't say, "I won't walk on the road at all because I could be knocked down by a truck." Because you said, that's a chance which is quite small, and therefore I'm willing to take it, and I'm not going to let this affect me. In healthcare, you don't have that. So some study will come. But the classic example, cholesterol. Total cholesterol was once anything above 200 was considered an indication for therapy. Then it became 180. Then they said, look, total cholesterol doesn't matter. Look at LDL. LDL more than 140, bad. More than 110, bad. Now it should be less than 100. Then they said, hang on a minute, LDL, but ApoB is a better predictor. So evidence is constantly changing. So we are being treated for things that we don't have and which we may or may not develop some years down the line. And we are not sure, based on current evidence, with what certainty we will develop them. So a lot of healthcare today is that kind of healthcare. And pharma runs largely on this kind of healthcare, not just the curative part of treating somebody for a disease that they have. So now with AI there, you can actually get a very informed opinion, relative and personalized and specific to you. Unlike Google, which would tell you, if you have a headache, it could be a tumor and so on, which is a general thing for everybody. But here you can actually feed your reports, you can feed your own data, and you can actually get insight. So I think that over the next 5 years in India, we're going to see patients, educated patients, start to use AI to understand their own conditions better and to validate whether what their doctor is saying makes sense or does not make sense.
But Dr. Sumanth, would this not? Okay, let's come to a very, very, very important point, because I want to also address the issues from the patient side, from us, from our end, because we are also part of this healthcare ecosystem. My fear with what you said, Dr. Sumanth, is that already what I'm seeing, okay, my approach is very systematic. There is a disease, there is a problem. I tell my parents and my spouse and let's go to a doctor. Let's take the medicines that she's prescribing. They know what they're doing. I always fail in this approach.
This happens, but by default, the first step has become of something called self-diagnosis.
Yes.
Patients do not realize that being a medically trained doctor is a very strenuous exercise, right? So they'll
Yeah.
go to the Google. They will write ki I'm having headache, I'm having severe this thing, and they'll suggest a list of AI powered now because Google is AI powered. The
Oh, yeah.
browsers has AI, so it's already there. It will tell you a host of symptoms. Then you go to any website, you find the medicines, and then you say, "Kya, just give me that Disprin. I'll take this antibiotic. I'll take that antibiotic," and they just pop it. Nothing will happen. They'll wait for 2 days. They'll keep on taking it. It will get worse, and then they'll end up in the doctor. So, two things I want to understand. A, is this mentality of self diagnosis, of Googling things, of taking antibiotics common to India, or is it a global phenomena? That is one I want to understand. Second, Dr. Suman, very important. What is this concept of, how do you call it? Over the top? No, over the counter.
Yeah.
When the pharmacist, okay, give me just 5 Disprins and he'll just take it out, throw the packet, just cut it like this and give you 5 medicines. Sometimes without prescription. There are certain medicines they don't even ask you. You show the WhatsApp photo, ki just give me this, and they'll just give it to you. So these two ecosystem I want to
Yeah.
understand. Is it wrong? Is it right? What is happening?
Yeah. Okay. So the second part I'll deal with first.
Huh.
Pharmacists in India, except narcotics, you can get anything without a prescription, right? The difference why you can't do this in other countries is you can't get antibiotics without a prescription in most developed countries. So you need a doctor's prescription who's a licensed professional in that country to be able to go to the pharmacy and get an antibiotic. In India, the pharmacist is the first port of call for a large proportion of people who fall sick. It is not the doctor. So somebody is not well, they go to the pharmacist and say, I've been having fever for 2 days, I've got this, I've got that. The pharmacist says, okay, take this, and they go. As you said, after 2-3 days, if it gets worse, only then the doctor is brought into the picture. Now, the point really is that, again, if regulation was tighter, they will not be able to get that antibiotic because the pharmacist will lose his license for giving the antibiotic without a prescription. But in India, nobody cares. I mean, you can buy anything without a prescription, right? The only thing there is some control over is narcotic drugs, where pharmacists are taken to task, and there's a huge license issue and all that if they give without prescription. But everything else, any pharmacy you can buy. That's one of the reasons why online pharmacies also haven't taken off in as big a way, because online pharmacies say you have to upload the prescription. So it's much easier to make a phone call to your local pharmacist. The boy will come in half an hour or 10 minutes and give you the medicines and go. Whatever you want. You want a third generation antibiotic, cephalosporin, no problem. They'll give it to you. So this is a problem. The first part of the question, actually, I am a person who's sort of biased because I work in AI. So I'm putting it out there, I'm biased. I think that an AI-based intelligence system could become the first port of call in the next 5 years. And I believe that patients in India could benefit massively from that, because the quality of the encounter with AI is getting better and better and better with every passing day. It's certainly not at all the Google experience where you generally put in something and it tells you something. Today, you can upload your X-rays, you can upload your CT scan reports, you can upload your lab tests, and get a very, very informed, reasoned opinion with evidence to back it and references. So I honestly feel, and I'm sort of more and more and more convinced as I work in this space, that in 5 years, your first port of call when you have a fever may not necessarily be to go to the doctor, but instead of going to the pharmacist, you could use an AI system which could tell you what could potentially be wrong with you, what you may need to do, what OTCs you may potentially need to take, and then you would be better equipped to take a decision on your health. And I can see that happening in 5 years.
So you're saying there can be a specific device. There
Yes.
can be a specific device as well, which can, let's say, have a camera on the front, which can also have a torch light. It can also say, can you turn on the camera, do this?
No,
It can also.
no, that's your phone. Your phone has a torchlight, your phone has a camera, phone has everything. It's your phone. There's not going to be a separate device coming from somewhere. And somebody who's there at home can take your blood pressure, can take your heart rate, feed it into the system, or you can dictate it into the system. Today, most of these systems are voice operated. So you can get a tremendous amount of support through targeted systems which have AI. So, like I said again, doctors will hate me for saying this, but I'm in this field, so I believe that this will happen. In India, the adoption will be slow, but once it sort of starts happening in other countries around the world, eventually it will trickle down to India.
But I think, Dr. Sumanth, I agree that this can happen. Why I feel this can happen? Because I am also a senior product manager in a tech company. I've
Yeah,
worked in AI and I've worked in health tech startups actually
yeah,
before. So I love this space a lot and I do understand technology as well. I think there is in this AI adoption of self diagnosis, the psychology of Indians is also a big factor. We already like self diagnosing ourselves because
yes,
we want to tell people that, Arey, I just took this medicine, I know this medicine, I was fine. We want to tell people, Acha, you have this problem, Arey, I'm telling you now, don't go to
mm,
doctor. I'm telling you, take these 5 medicines and you'll be fine and you'll thank me. We already have that psychology of know it all.
yes.
So this psychology of know it all and self diagnosis, when combined with the AI tools, I think. But Dr.
And
Sumanth, let's
Raghav,
say,
it's also in your language. It's in your native
ha,
language. You want it in Hindi, you want it in Odia, you want it in Malayalam, any language. So you talk to the system in your own language. It responds to you, asks you more questions. It asks you what is your blood pressure. Ask somebody to take it. You're even potentially you have some relative who can take your BP and take your pulse and take your oxygen saturation, feed it into the system, and then it says, okay, maybe you want this lab test, and all of it in your language. So potentially you could see why this could become very attractive. And let's face it, I mean, all of this at maybe 2 rupees or 3 rupees or 5 rupees, which is, you would spend much 100 times that going to a doctor.
but let's say after this diagnosis by an AI tool, it generates you a prescription. Would that prescription be acceptable, let's say in certain places wherein it is required to dispatch the medicines?
That is why government needs to look at adopting these technologies, because the greatest impact will be on the poorest patients. They will be the ones who benefit the most, because they are the ones who are struggling to get quality healthcare. Look, Raghav, here is a system where the richest individual in India and the poorest man in the poorest village will have access to the same level of AI intelligence and expertise that the system can offer. What could be better than that? So it's for the government to sort of adopt, but sadly, I don't expect governments to adopt anything with a visionary kind of approach. So it will take time. But the bottom line is that you know patients could benefit hugely from something like this. At a primary care, I mean, you don't have to, obviously you don't want to start putting them on dangerous medication through a prescription given here, no. But at a basic level, what could be wrong? What are the tests that he may require? What should be the lifestyle changes that he may need to do? Modifications that would help. When is it? Is it something that he needs to see the doctor immediately? Whole lot of things can potentially help these patients. And these are people who could be living in 50 kilometers away from the nearest doctor. So what do they do? So I think if government adopts AI in a big way in healthcare, can have a massive impact. The point is, will they? I don't know.
Yeah. This would require the government push because when COVID happened, telemedicine was on a rise. People were doing teleconsultations and doctors were earning good amount of money.
Yeah.
And I genuinely thought, Dr. Sumant, that this telecommunication would become the new norm. Just the way I thought work from home would become the new norm, but no. People reverted back to the systems. And when I saw the moment the COVID ban was lifted, people flocking to two places, places where they serve liquor
Yeah. Yeah.
and to the doctor's clinic.
Yeah.
And when I even told my mom that wasn't it good that you were able to consult with the doctor virtually when you had COVID, you know what she told me? What I told you initially. She's like, Raghav, when you see a doctor, when you interact with him, that cures faster than anything.
Yeah.
So this is also, I have got to know the rural Indian mentality is
Absolutely.
still to go and visit the doctor so that they can talk not just about the disease, but cricket,
Yes.
politics,
I-
panchayat.
Absolutely. Yes. 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 That's a very important part of when I was young, the doctor I used to be taken to when I was a child. Um, invariably would discuss my condition for about 5 minutes, and then we'd spend 20 minutes talking about cricket.
Yeah.
And when we came out, my mom would say, obviously, it can't be anything because we spent most of the time talking about cricket. So if it was something serious, you would have definitely taken it more seriously. So that itself had a much really. You're right. People come to the doctor often to have an outpouring session, to vent, to talk about their other problems. So a lot of reasons. Yes.
So, Dr. Sumant, now there are only two things which I just want to discuss. Now, I want to discuss on this entire, another highlight, and I want, then what we'll do, we'll take a use case. Okay.
Yeah.
The nexus between pharma and the medical industry is deep and all encompassing. To answer this now, Dr. Sumant, I would want to take the use case of COVID. Okay. I don't know what happened in COVID. COVID came. In 6 months, there was a different war going on of vaccines. The news media, the portals, it was all about the war of vaccines, right? It was like a sprint. It was like an Olympic sprint. Which country's athlete is going to win? It became a war. For the first time, I witnessed a medical war shaping up in the global space, right? So I want to take up this example of the pharmaceutical industry with respect to COVID and what the hell happened in vaccines. Was it genuine? Was it tested? In 6 months, somebody is coming with a vaccine. India is coming with a vaccine. Russia is coming with a vaccine. Sputnik. China is doing something. So just explain the entire pharmaceutical angle of healthcare with respect to COVID and India.
Yeah, I think COVID would not be a right or appropriate example, though it was very famous, because it was an abnormal situation. It was a pandemic which was happening after, almost over 100 years. And we had never seen anything like it in our lifetimes. And governments were forced to react in an emergency kind of a situation. Normally, a vaccine before it comes out into the market would take a minimum of 10 years of testing, trials, and all of that. So you can't sort of identify a vaccine which works today and put it out into the market in 4 months or 6 months' time. No way. It'll at least take 5 to 10 years. So in COVID, you had no time. So what did you do? You had to come up with something to. There were two reasons. One, from a scientific medical perspective, you had to come up with a vaccine because people were dying in their millions. And also from a political perspective, governments must have wanted to be seen to be doing something. You can't just say, no, we don't know, we just hope it goes away. So the point was, where corners needed to be cut, they needed to be cut. And unfortunately, yes, that did happen. But I would not blame the governments for what they did then, because they were under a lot of political pressure to deliver something, even if it worked 20%. Still, something had to be given to the public. You can't just say we can't do anything. So that was the reason why. And mRNA vaccines, by and large, the ones which came in from which the US found through Pfizer and so on, are relatively newer vaccines. They're not like vaccines which have been around for 50, 70 years or 80 years. They're relatively newer vaccines, and therefore there were issues with them. But apart from COVID itself, if you take the nexus between pharma and doctors in India, it's extremely strong. It's not just pharma; it's also the diagnostic centers. So the system of kickbacks is a very well-oiled kind of a system. And again, I want to say that there are lakhs and lakhs of doctors who simply do not take kickbacks, who do not interact with pharma, who maintain a very, very healthy distance from both these unethical practices of collecting kickbacks. But sadly, there are many doctors who are also collecting the kickbacks from pharma and diagnostic centers. So the problem is, how do you weed it out? Again, it's a regulatory issue. There's no regulation. So pharma companies, so typically what happens now, there is obviously a pharma company cannot say, I paid this doctor this much and write it in their books. So there will be some third party agency which would be hired. that third party agency will be given a contract. There will be no service which is delivered for that. That money is actually meant to go to the doctor. So it will go through a roundabout route and it will be paid. This happens all the time. So the point is that government needs to take firm measures. I'll give you an example. Government brought a rule which said that the individual pharma companies should not be paying doctors for pharmaceutical for conferences and stuff like that. It should be through the associations or the organizations. There was an uproar. There was a uproar, and the decision was put on hold in 2 weeks. I had written about it in an article where it lasted hardly 2 weeks. Within 2 weeks, as if entire medical education and learning and continuous medical learning, everything will come to a halt if the association was paid instead of the individual doctors by the pharma companies. I mean, the government succumbed. They backed off. So I think there is a need for better, more stricter regulation. This kind of conferences. I mean, why do conferences need to be held in 5-star hotels only? I mean, does the learning become less if you hold it in, say, a 3-star hotel, or if you hold it in a medical college hospital auditorium? I've never understood this. I mean, the why do medical conferences need cocktails and dinners sponsored by? Why do they need cocktails sponsored by pharma companies? Now, again, all of this on paper is being taken out. So there is a roundabout route by which this whole thing is organized. But it happens every day. And government doesn't seem to think, there's any need to change all this. So that's a fundamental problem.
Dr. Suman, when you were talking about there are certain doctors which do have a kickback to pharma, can you explain this term? What do you mean by kickback?
Okay, so basically, it extends all the way. It could be at one point of time, there were companies which would give coupons. They would give fuel coupons. So let's say you've written drugs for a particular value, that particular company's brand. And these guys are very smart because they know which pharmacies the patients nearby go to. Very often in a small town, there will be a pharmacy attached to the doctor's clinic, or there'll be one just next to the doctor's clinic where the patients will go and buy the medicines and so on. So the pharmaceutical company reps know the amount that you have generated for them. So based on that, they will drop off fuel coupons. Everybody has a car, right? I mean, you'd want to fill fuel for your car. There'll be supermarket coupons. There'll be offers. And then of course it gradually goes up to flight tickets. It goes up to, in fact, I've written about that one where a doctor was furious. And I literally, I mean, I can picture it happening, seeing it in front of me, though it happened many, many years ago, where the rep came back into the room and he was talking to me and he was cursing a very, very senior consultant. He said, "Sir, we organized a ticket for him. He said it should be business class. We upgraded him and got him a business class ticket. Then he said he wanted a ticket for his wife. We bought a ticket for his wife. And now he's furious that we've got his wife an economy ticket. He says he can't sit in business and his wife sit in economy. He wants his wife's ticket to be upgraded." So what do you do? Now, obviously, the doctor is going to have to write a lot more prescriptions in the next month to make the business class ticket worthwhile for the pharma company. That's a problem. It's a problem. I mean, we can shut our eyes and say all of it doesn't happen. And I again want to place on record, there are lakhs of doctors who do not have any truck with pharma, who do not have any truck with diagnostic centers, who do not take kickbacks. So we have to acknowledge them and salute them, because they are the ones who are keeping this entire, ethical healthcare system going. When around them, they're surrounded by people who are into the kickbacks game.
Dr. Suman, the common medicines that we go to the pharmacist and we take like Crocin, Combiflam and XYZ, I have heard from many people, so I just wanted to understand the reality. A lot of people say that these pharmacies who are giving the medicines, they're not real medicines. They are fake medicines. So let's say a Combiflam that you might get, which of the company produces that in India, or the Combiflam that you might get in any other country, there's a difference between the quality. Just like you say, if you are selling Coca-Cola in India and if you're selling Coca-Cola in Paris or France, there's a difference in the sugar level, right? Same brand, same company. Does that happen in the is this also problem in Indian pharmaceutical ecosystem that the medicines sometimes could be fake, though they're branded, though they are of the same name? I just want to demystify this thing. What is happening over here?
Okay. I would not be the appropriate person to give you numbers on this because I'm not from the pharma industry, as it were. But I think the important thing is the honest answer to this question would be nobody knows the extent of the problem. We know that the branded pharma large company sectors which work in India, by and large, would not be doing this on a large scale. There could be things here and there that could be tampered with, but I don't believe, or I don't think. I think that the drug regulatory mechanism would not allow it among the larger pharmaceutical companies on a grand scale. Again, I could be completely wrong because my knowledge on this subject is limited. The um, part where the smaller companies are concerned, and we saw what happened with the cough syrups recently, the
Yeah.
cases in Tamil
Yes.
Nadu and so on.
Yes.
That is quite rampant. I mean, that is quite rampant. Most of the time, it's not dangerous stuff in the medicine, but probably harmless stuff like chalk powder and stuff like that, which is not going to kill you, but it's not going to treat you either. So those kind of issues are believed to be rampant. Again, you should talk to somebody like Dinesh Thakur or somebody who's in that field, who's written about it, who can tell you more about this nexus with pharma.
Yeah. Now, Dr. Suman, to end this entire conversation, I would want you to give us very briefly, you can just summarize some of the solutions, some of the things that you feel the government should look into, the people should look into, and the doctor should look into. What is one thing that you want government to do? What is one thing that you want people to do? Patients, people to be aware of, and what is that one thing you want the doctors to also do so that we could convert this sick business into a pious business? Because I do know it is a business and it has to be a business,
Yeah.
but the nomenclature can change.
Okay. For the government, it's very, very clear, very simple. You have to spend double or triple of what you're doing on improving public health care. The present spend is simply not enough, and it is condemning millions of people to ill health and to, to death, even because we are not spending enough on quality health. There's nothing which is more important for a government to do than health and education. I can't think of anything else. Obviously, we assume that they've solved the problem of food and and shelter, but these are the four things that people need: food, shelter, education, and health. And nothing can be more important than actually spending on health. So the government needs to spend more. The government needs to regulate healthcare more effectively and monitor outcomes. Currently, there is no outcome assessment in healthcare in India. So that needs to change. And the third, very, very important, they need to make maintenance of records electronically mandated. So if the three things that I want the government to do, double your spending or triple your spending, may not happen immediately, but do it over the next 5 years or 10 years. Introduce mandatory electronic medical records, give people 5 years time to implement it, adopt technology extensively in patient care, and of course regulate the corporate sector as much as much with a focus on their outcomes. So these are the things for the government. For the doctors, I'd say, look, I think that there is a need to understand our limitations. There is a need. Okay, we are not any longer seen as gods. I think that we have to, the patient is now having a very, very skeptical eye when he's looking at us. He's trying to see, okay, what is this guy trying to rip off me? So I think that idea has come to the patients, and that we are responsible for that because of how some of us have behaved. So I think for the doctors, empathy, ethics, all of these values which need to come into, have to be introduced into medical education. Again, that's partly the government's responsibility, but it's important that doctors understand this. Second, adoption of technology. A doctor with AI is going to be a much better doctor than a doctor without AI. And you can't just shut your eyes to the technological advancements in the world and pretend that nothing will impact you. So that's the second part. The From the third part, I can't go into sermonizing for doctors saying that you should not succumb to the temptation. We're all human. We don't know, depending on people's need for money and all that, how anybody would react. So I'm not going to sit in judgment on them. The third part is from the corporate sector. I think that there needs to be some kind of an understanding of what profitability could be and should be. So it can't be, year on year 50%, 40%, 30%, or whatever. So whatever, that's not happening in the current situation, but that's because of a separate topic. For the patients themselves, most important, one, always, if you are diagnosed with a major condition, get multiple opinions. That is the most important. I've written it in the book. At the last chapter is basically on how to be better empowered. One, get multiple opinions. If you're advised a surgery, never go in for a surgery just on the basis of what one doctor told you. Get multiple opinions. Second, get yourself health insurance. It could be saving not just your life, but your family's future. So please get yourself health insurance. There is no substitute. It has got a lot of flaws. There are a lot of problems with the health insurance system, but you're still better off with health insurance than without it. So please get yourself health insurance. And the third, ask. Never be afraid to ask. I think that that's very, very important. When we go to a doctor, sometimes we get intimidated. We are in a big hospital. I'm scared what this man will say, what that lady will say. No, it is your right to be fully informed about your health. Collect all your records. It is illegal for a hospital to deny patients their own medical records. You have every right to your record. Get all the details and keep it. And 5 is something that I'm looking forward to in the future. Adopt technology yourselves. Try to be more informed about your condition. AI is becoming better and better and better at it. Maybe in 3 to 5 years, you will be able to be more empowered about your. So these are the things that I thought I could share with patients.
Beautiful. That is beautiful. And Dr. Sumanth, with this, we come to the end of the podcast. I hope you enjoyed it, Doctor. I hope we were able to do justice to the topic and give people enough information and push to purchase the book. That's always the agenda, to always have discussions around the subject and not reveal everything and let them go deep.
Absolutely.
Into the topic.
And again, as I said, Raghav, I want to again reiterate that there are so many of my colleagues in the profession who are doing great work. And this is not meant to, cast any aspersions on the remarkable work that they continue to do. It's just that we need to figure out a way to change the system that is leaving the vast majority of our citizens behind, which is pushing a large number of them into poverty. So I think that it's a duty of every Indian to see how we can work to make this better for all of us.
Absolutely. Absolutely. It's very important vertical, and it's high time that people start taking it very seriously and they become aware of that. I think that's important. Thank you, Dr. Sumanth, for your precious time. I will keep you updated, sir.